the head will keep secreting FSH. Well, yes, indeed. When these protocols appeared in our domain, we got another intermediate option between standard protocols and the natural cycle. In fact, this random start option is far from surprising. We have already covered direct stimulation. In addition, some other impressive drugs called indirect triggers of folliculogenesis are available. We boost one's head's activity by prescribing these drugs, namely selective estrogen receptor blockers, letrozole. They block estradiol receptors, thereby causing the peak value of one's own FSH via negative feedback. You know, two groups of patients adhere to these protocols. First, I mean the patients who used to undergo or still undergo minimal stimulation within the well-known Japanese minimal stimulation protocol. However, similar protocols had been used in Russia before. Nevertheless, according to it, when we prescribe clomiphene-based drugs starting from day 2 to 3, we may either follow the protocol as it is by administering these specific drugs or in combination with the same gonadotropins prescribed at standard stimulation. The second group, for which all of us are an old hand at administering letrozole, encompasses the patients involved in the onco-fertility program. Our capacities are truly limited in this domain, and it is of prime importance to halt the increase in estradiol level. It is letrozole which retains the estradiol level during the natural cycle. Thus, 5, 10 or 15x resulting from medication are a fantastic outcome even for those who beware of our hormone drugs or a rising estradiol level for some reason. Now we move on to the logical aspect of these protocols. We have two scale pans. We put the impact of the pituitary gland on the ovary onto the first scale pan, and the reverse impact of the ovary on the pituitary gland or on the hypothalamus, on whichever head structure onto the second one. The pituitary gland secretes FSH, which induces follicular growth. Definitely we benefit from it. When we perform direct stimulation, we also put external FSH onto this scale pan in order to enhance the continuous follicular growth. On the other hand, growing follicles per se produce estradiol, which inhibits FSH secretion. It is a so-called negative feedback. Unless estradiol reaches the head, it will keep producing FSH. Then the follicles will remain growing without us, it acts without any administration of extra FSH. One may circumvent the head in two ways at various stages. First, one may thwart estradiol production using an aromatase inhibitor. Basically, it is aromatase which converts testosterone to estradiol in the follicles. Second, one may let the follicles secrete estradiol into blood without being spotted by the pituitary gland and the hypothalamus. In this regard, the second group of drugs, including clomiphene-based drugs, is needed. Well, yes, indeed. When these protocols appeared in our domain, we got another intermediate option between standard protocols and a natural cycle. In fact, it is still a good option for the patients with diminished ovarian reserve or the ones who have already adhered to numerous protocols, and for whom we know that dose escalation does not give rise to new follicles, but merely increases the medicine-related burden. Hence, these protocols invariably ensure the indispensable number of follicles without any escalation of the total dose of FSH drugs. It is one of the key features of the protocol-related body burden. Therefore, as far as you can imagine, not only can these drugs be used in IVF programs, but also in stimulation and insemination programs. In my opinion, they cannot either be discontinued from IVF cycles. Some people are positive that they are outdated and no longer efficacious. I totally disagree with this standpoint. In fact, they guarantee the same quality of eggs, while less funds are spent for these medicines and treatment. Thus, it is worth using them. Another important issue, which we would like to tackle, is the following. I was taught 15 years ago that induction of superovulation is directly related to menstruation within any IVF program. The menstrual period was of paramount importance for us. It is common knowledge that we often receive calls or text messages in which someone informs us of the beginning of the menstruation, asking us to make an appointment. These hustle and bustle frequently occurred on Fridays or the weekend, whenever. In the past, it was believed that all of our follicles start growing at a certain day of the cycle and we should keep pace with that. Ovarian drilling is scheduled for the middle of the cycle, followed by an embryo transfer. The inception of oncofertility programs revealed the fact that female bodies are much more complex and interesting than expected. As a matter of fact, follicles are recruited on a daily basis. Thus, we may prescribe stimulation, not at random, but irrespective of the menstrual day. So-called random starts took place later. Women used to see us for an ultrasound examination where we did not identify any contraindication to stimulation and to undergo this particular stimulation on day 9, 15 or 20 of the cycle, whenever. It was primarily applicable to the patients whom we were able to treat over extremely limited time, since they were followed up by oncologists. Official duostims and triostims, double and triple ovarian stimulation respectively, occurred afterwards, implying that several attempts of follicular maturation are originally presupposed by both a doctor and a patient. If she prepares for it while on priming, we should expedite her treatment. Therefore, the first stimulation stage occurs, the ovaries are punctured. The patient undergoes the next stimulation stage in 2 to 3 days, which turns out to be more effective than the first one. We may yield more embryos for future transfer over a short time span. In fact, this random start option is far from surprising. As far as you know, any follicle grows for roughly 6 months, but we are actually aware of only 2 weeks from menstruation to ovulation. As for the previous 5.5 months, at least 5 months, it grows without any relation to the menstrual cycle. In this regard, there is no difference in a woman's days of life. It is the matter of appropriate timing. Yes, you're right. It is more convenient to initiate stimulation of fine, absolutely homogeneous ovaries at the outset. I still enjoy it. Anyway, it is the beginning of menstruation when we first face discharge. You should be fear-resistant when you find a corpus luteum or a big follicle in the ovary at the beginning of stimulation. The second point that I would like to stress is that we cannot transfer an embryo in some cases. It is crystal clear because the ovarian drilling may take place during the premenstrual period when no transfer is feasible. Anyway, we discuss it with our patient because our today's goal is to grow as many follicles as possible. We will transfer them as soon as we are ready for that, be it within a natural cycle or on hormone replacement therapy. Thus, if no fresh embryo transfer is required, which is considered mauvais ton in some clinics, why do not we follow the known procedure? We ought to stimulate the ovaries, obtain the embryos, freeze them, enable a woman to unwind and get ready for a transfer. Well, to call it mauvais ton is an extreme case. But anyway, embryo cryopreservation is very effective at present. Let's knock on wood. Hence, freezing and thawing an embryo will not be detrimental to its quality at all. Accordingly, we are not committed to transferring an embryo in the fresh cycle. We may be guided by other considerations. It is one of the reasons why random starts are feasible. Thank you.